increases walking ability in patients with intermittent claudication. Michael van Scherberg from Norway.
Thank you very much for this introduction. Dear committee, dear audience, and dear friends, thank you for giving me the possibility to present home-based. Oh, I have to start it. Calf raise exercise increases walking ability in patients with intermittent claudication. In 2013, an article published in The Lancet estimated that there are 202 million people with peripheral arterial disease. The prevalence of peripheral arterial disease increases with age, and the number of patients can be expected to increase further as the population of Europe is aging. The primary reason behind the pathophysiology of peripheral arterial disease is a reduction of blood flow. This results in a reduced oxygen delivery, and adequate oxygen delivery is necessary for the muscle cell to produce energy. Peripheral arterial disease are clinically divided into 3 levels, depending on the severity of symptoms. Usually, this is measured with the ankle brachial index. The index is reached by dividing the blood pressure in the arm by the blood pressure in the ankle. In normal circulation, this is usually between 1 and 1.1. Peripheral arterial disease can be asymptomatic. Patients do not experience any pain, and the ankle brachial index is usually below 0.9. Intermittent claudication is characterized by muscle discomfort or pain induced by walking and relieved by rest after a few minutes. The ankle brachial index is usually between 0.4 and 0.9. And critical limb ischemia is a decrease in limb perfusion that causes a threat for its viability. Symptoms are rest pain and or non-healing ulcerations. The ankle brachial index is usually below 0.4. Patients with intermittent claudication can complain about pain and exertion in the buttocks, thighs, and calves. This study focuses on patients with intermittent claudication with pain in the calves. The primary therapy consists of giving antiplatelet and lipid-lowering drugs, smoking cessation, and initiatives to increase physical activity. This can be summarized with stop smoking, keep on walking. If this does not relieve symptoms, interventional treatment is traditionally considered. Then angiography is performed to localize stenosis, resulting eventually in surgery. However, the latest guidelines recommend that exercise treatment should be part of the primary therapy in the management of intermittent claudication, as it improves walking ability. Supervised exercise seems to be as efficient as endovascular surgery. Therefore, patients with intermittent claudication should initially be referred to exercise treatment programs. Supervised exercise programs are lacking in European countries. One reason being that the number of patients are huge. Several studies evaluating home-based exercise have shown a positive effect on quality of life, increasing daily physical activity and walking ability. Therefore, guidelines also recommend that home-based unsupervised exercise should be advised when supervised exercise is not available. But problems are low compliance, the instruction of exercise can be misunderstood, and it most often exists of walking, which induces improvements in non-specific muscles for patients with intermittent claudication. Besides the specific type of unsupervised exercise, the compliance to a given instruction is just as important. The instruction should be simple to understand and concentrate on the muscle of interest. The overall clinical key for this study is to try to contribute with a new potential home-based training concept with an easy instruction. This study introduces a home-based calf raise exercise entitled 5+. And 5+ consists of the patient standing in front of a wall